We're now beginning part 2 or lecture 2, hour 2 of this 3-hour presentation. In the first hour we covered the topics you see at the top, and now down through otoacoustic emissions. And now we're going to focus on auditory evoked responses in neuroaudiology diagnosis. Now this first hour, or this next hour I should say, covers the first two of those evoked responses, ECoch and ABR. The third hour will cover everything else, the steady state response, middle latency, late, P300, and then at the very end I'll pull everything together with a little review of how combining all of these different measurements, auditory evoked responses, middle ear measurements, and OAEs in a test battery can always allow you to differentiate among different sites of auditory dysfunction and allow you to evaluate pretty much any patient, no matter what their age, cognitive status, or anything else. Okay, so let's move on. My experience with auditory evoked responses goes back to really when I made that conversion from speech pathology to audiology. So I've been very fortunate to have pretty much developed my entire career along with the development of auditory evoked responses. Now in the early years, from 1974 up probably to about the early 1980s, so about 10 years, most of that experience was with ABR alone. And mainly I got started with ABR because Dr. Jerger was already using a very homemade rudimentary ABR system that was put together in the clinic. But as the years went past, we get into the late 1970s and early 1980s, you could go out and buy, as an audiologist, a system for recording ABR such as this Nicolay CA1000 that you see in this slide, the blue machine. And so beginning then, we recorded ABRs routinely in children and sometimes adults. Now with these systems, it was also possible to record some later responses by manipulating the parameters. And by the early 1980s, many of us realized that the ABR was great, no question about it, but it didn't provide us with any information on cortical functioning. And we had children and adults who we were quite sure were at risk for higher level auditory dysfunction. So we started to focus more of our attention on the middle latency response and the late response. And then, of course, as we're going to discuss next, with the discovery, quote unquote, with the realization that some patients had neural problems, including young children, and they didn't have tumors, they had a neuropathy without a tumor, we began to focus also on electrocochleography. So we're going to start with electrocochleography and we're going to work our way up. Here are the different major evoked responses that we can record in the auditory system from the cochlea all the way up to the cortex. Now I say major because there are many other auditory evoked responses, particularly when we get up to the cortical level. There are literally dozens of variations of cortical evoked responses, but many are not used, most are not used by audiologists. Some of these cortical responses are distinguished by the types of stimulus, others by the requirements made of the patient or the subject. We're going to focus on these responses because they're the ones used most often by audiologists, and we're going to work our way up basically anatomically from the cochlea to the cortex. Now, I've written a bunch of books, as you know, 10 of them, and the most recent is a book on Auditory Evoked Responses that is totally a new book. It's not a revision of any previous books I've written on this topic. And this is what the cover looks like. And if you go to Amazon.com, you can download it to two devices, two electronic devices. You know, it could be some kind of computer, laptop computer, let's say. It could be your phone if you wanted to. It could be some type of tablet. Yeah, so you can download it to two devices, and there are many advantages to ebooks, which I won't go into here. One of them is cost. The price can be kept very, very modest. If this were a printed book and it were being published by a publisher, it would be well over $200, but it's not that at all. It's much less. It's $74. But it's got a lot of information. In fact, if you did print it out, it would be over 1,000 pages. It's everything that I could think of that an audiologist would want to know about auditory evoked responses. So if you're wanting more information on any of the topics that I'm discussing today in my lectures, and you'll see many of the figures actually are from this book, this is a good place to get that information. All right, so let's begin with ECoch, electrocochleography, and we're going to talk about the anatomy, the physiology, and some of the clinical applications, but we're also going to focus really on the test protocol that you need to use to record ECoch, because the test protocol is really a variation of what you'd use for ABR. So any of you who are already recording ABR can easily adapt your equipment and adapt your protocol to record electrocochleography. Very briefly, as I mentioned earlier, I mentioned in the live introduction, we're going to go through each of these lectures following the same format, and you've already seen the format when we discuss middle ear measurements and OAEs. And the first thing I always do is to highlight the historical development of a response, and particularly highlight the people or person who was most responsible for discovering the response or for introducing it clinically. And for the ECoG, there's one person that, without any doubt, that deserves the credit for discovering the response, and his name is Glenn Weaver. He's now deceased. He was a very well-known auditory scientist, auditory physiologist at Princeton University for many, many years, and published the article in 1930. So it turns out if we follow evoked responses from an anatomic sequence from cochlea to cortex, we're actually also starting with the chronologic first response discovered in 1930. There were no auditory evoked responses discovered before that. In fact, even the EEG, basic measurement of brain activity, the EEG, was only really discovered a short time before this. Now, there are many ways of recording ECoG, but the traditional way, actually, depending on where you put the electrodes, the waveform may be with waves going up or down, but the traditional recording approach always had the waves going down, and these are two of the major ECoG components. The SP is the summating potential, and the AP is the action potential. And this slide also shows that you can measure the latency of the response, that is where the peaks occur after the stimulus, in time, in milliseconds. You can record the amplitude of the response in microvolts from some baseline to the peak, or you can measure the duration of the response, that is, when it begins and when it ends. Most of the time we're looking at amplitude for ECoG, and the amplitude of different components, the summating potential, the action potential, or the cochlear microphonic, which is not shown here. So those are the three main excuse me, components of the ECoG, and although they all come from the cochlea, technically, the action potential is really a neural response. It's a neural response from the auditory nerve fibers as they leave the inner hair cells where they synapse. So it's within the structure we consider the cochlea, but it's technically a neural response. The other two components, cochlear microphonic and summating potential, are only cochlear responses. There's no neural involvement. Now, it's likely that each of these two components, the cochlear microphonic and the summiting potential, gets its energy and is produced, at least in some part, by multiple structures within the cochlea. But if we had to say, well, which structures contribute most to the cochlear microphonic, which without a doubt it's the outer hair cells. And when the outer hair cells are damaged or destroyed, the cochlear microphonic disappears. The summiting potential for many years was attributed to the organ of Corti, but that's kind of a broad generator because there's multiple components within the organ of Corti, particularly the inner and outer hair cells, and then there are some other hair cells, and of course there's plenty of fluids and a lot of electrical potentials just within the organ of Corti. But research on animals where the inner hair cells were selectively damaged, usually through an ototoxic drug in certain animals, has led to the conclusion that a good part of the summiting potential is produced by the inner hair cells. There is definitely outer hair cell involvement, but once you destroy the inner hair cells, the summiting potential pretty much disappears. So this is kind of a good fortune for us because we've got one response, cochlear microphonic, that we can use to assess integrity of the outer hair cells. We've got another separate response in the ECoch, which can be used to assess the integrity of the inner hair cells. And then, of course, we got the action potential, which is really many action potentials, thousands, which is definitely a neural response. And we're going to come back to this point a little later on in this first part of the lecture when we talk about auditory neuropathy. We've got responses that come from different structures that are in the same region where we suspect the problem will lie for auditory neuropathy. So just a quick wrap up, we've got the summiting potential and action potential, the summiting potential and cochlear microphonic coming from within the cochlea itself, and here are the structures: inner hair cells for summiting potential, outer hair cells for cochlear microphonic, and then we've got the action potential coming from where you can see where the arrow is pointing. It's pointing to the auditory nerve fibers as they are leaving the cochlea, but they're still within the bony structure of the cochlea. Now, real quickly, and I don't have time to go into this in great detail. If I were giving a one-day workshop, I'd really focus on a lot of these parameters and we talk about their effects on the response. But I'm just going to quickly go through this now, and you can always review the PowerPoints later, or better yet, buy the book and read the book. So you can use clicks or tone burst as your stimuli for ECoch. Clinically, we usually use clicks for most purposes, but there definitely are many research papers describing tone burst, and in certain populations, such as patients with Meniere's disease, low frequency tone bursts actually have some advantages. The duration, if we're using clicks, is the same as for ABR, and of course we can record ECoch with an ABR system. The rate really depends, the rate of stimulation really depends on what your goals are and where your electrodes are located. If you're using an electrode close to the cochlea, and we're going to describe them in a moment, and if the ECoch is huge, you can get by with very fast rates because the response will still be big. But if you're using an electrode in the ear canal, for example, and the ECoch is not that large to begin with, you may need to slow the stimulus rate in order to see all the responses clearly. Polarity is not a big issue in a lot of responses, but it's a really important parameter for ECoch, because with ECoch, changing the polarity actually just determines which of these components you're going to record. So if you want to record a summiting potential and an action potential, a good polarity option is to use both rarefaction and condensation in an alternating fashion. But if you want to only record a cochlear microphonic, then you must use the single polarity stimuli, rarefaction and condensation. Intensity, obviously we're always varying that, but the intensity also depends on how you're using the ECoch. If I'm monitoring a patient in the operating room and I'm combining ECoch and ABR for that purpose, I usually stay at a high intensity. On the other hand, if I'm trying to find threshold in a child, and then I'm going to manipulate the intensity down to lower levels. We usually use insert earphones, and masking is never needed. That's pretty obvious, but let me just explain. And this is an important point for recording air conduction and bone conduction ABR as well. If we have an electrode near the ear, and that electrode's detecting the response, and maybe we put an electrode near the other ear, the non-test ear, and there's nothing happening with that electrode, then we know that the response we're recording is ear specific. It's coming from the ear we're stimulating. That's always the case for ECoch, but we can use that ECoch principle to avoid needing masking in performing ABR, even for bone conduction. And we'll come back to that later. So here's an example of manipulating the stimulus intensity to differentiate between the three components. Single polarity produces cochlear microphonic and the action potential, whereas alternating polarity, for the most part, cancels out the rarefaction and condensation cochlear microphonic, leaving instead just the summating potential and action potential. Now they're always all there. When we stimulate the ear with any kind of sound, we're always going to record a cochlear microphonic, a summating potential, and an action potential, assuming the ear is normal. But when we're recording them, we can't see the summating potential if we're using a single polarity. It's just overwhelmed by the cochlear microphonic. So to get rid of we get rid of the cochlear microphonic in order to identify the summating potential. Now, this is an example of one of my patients many years ago with about a 60 dB hearing loss. The ECoch is being recorded with a needle through the eardrum onto the patient's promontory in the clinic. The eardrum was anesthetized locally, and on the right side you see an ECoch with an alternating polarity stimulus showing a beautiful cochlear summating potential, and action potential, and you can see the ratio of the summating potential amplitude divided by the action potential amplitude is 40%. You can see the responses are quite big. The action potential is 2.11 microvolts. I mean, that's 8 times, 9 times bigger than an ABR. Over on the left, you see just rarefaction stimulus where there's a lot of cochlear microphonic there plus the action potential. Now, detecting the summating potential sometimes is really important, and as we discuss auditory neuropathy, you'll begin to appreciate that, because sometimes we want to know, is the auditory neuropathy problem involving the inner hair cells, or is it not involving the inner hair cells? Well, recording or not recording a summating potential can answer that question. So here's some tricks or techniques for identifying the summating potential, which sometimes is a little hard to see. The summating potential appears as a little shoulder on the beginning portion of the action potential. But if you want to make sure that's truly the summating potential, one way to do that is to stretch out a tone burst signal, 5-10 milliseconds, and anytime that ear is being stimulated, there will be a summating potential. The summating potential is always there as long as there's a stimulus. And so if you have a long duration, the action potential is long gone. It occurs only at the onset. But at the very end of the stimulus, you'll see a drop in the response you're recording, and that'll confirm that that was all summating potential. Another strategy you can use to detect and confirm the summating potential is shown here. We know that the summating potential is observable at a slower rate of stimulation, but so is the action potential. As we increase the stimulation rate and we get up into the 90 per second range, so now there's 90 stimuli in a single second, the action potential just can't keep up. The auditory nerve fibers are just overwhelmed by that very, very fast rate. So that action potential disappears. But what is left is the summating potential, because as long as we have a stimulus presented to the ear, we'll have a summating potential. So those are two techniques for helping you to confirm that there really is a summating potential. Moving on with the protocol to the acquisition parameters, you can see that many of them are very similar to the ABR. Uh, we use a shorter analysis time typically for ECoG because the response is occurring within the first 2 to 3 milliseconds, but we could use an analysis time for ECoG that actually allows us to also see the ABR. I would do this quite often in the operating room, where I'd be looking at both ECoG and ABR simultaneously. The filter settings are not that different from ABR, but we want more low frequencies for ECoG because the summiting potential is basically a lot of low frequency energy. So we don't want to filter that out. Now, the electrodes are the big difference between an ABR and an ECoG. With an ABR, we usually have electrodes that are non-invasive, maybe on an earlobe. That's a very good location for the inverting electrode. But for the ECoG, we want to get the electrodes as close to the cochlea as we possibly can. So there are really three options. The best option from a point of view of getting a big ECoG, a clear ECoG, is the transtympanic needle on the promontory. The next best, which is actually feasible for audiologists, is a tympanic membrane electrode, and the least useful ECoG electrode is a tiptrode in the ear canal. It's least useful because the response is so small. So if one of the general principles of ECoG is the closer the electrode is to the cochlea, the better the response. So again, these are our three options. Tiptrode as far down in the ear canal as possible. A TM electrode, which is perfect for audiologists because it's non-invasive, but it's actually getting quite close to the cochlea. But if I'm recording an ECoG in a clinic where there's an otolaryngologist or maybe an otologist, I'll always prefer to have a needle inserted through the eardrum onto the promontory, because then you're as close to the cochlea as you can get. Getting close to the cochlea is important because ECoG is a near field response. In other words, that when you're really recording an ECoG properly, you have an electrode right within the electrical field that you're detecting. ABR, in contrast, is a far field response. With ABR, none of our electrodes are actually where the response is being generated. They're many, many millimeters, actually centimeters away. We can't get an electrode in the brainstem or on the auditory nerve. But with ECoG, we're getting an electrode just within a millimeter or so of the actual generators of the response, which are either in the cochlea or the auditory nerve, particularly if we have a needle on the promontory. The promontory, of course, is the inner wall of the middle ear, but it's the outer wall of the cochlea. And that's illustrated here. If you get the needle, I should say the electrode, very close to the dipole, the positive-negative source of the response, then you're going to get a huge response. And as soon as you start moving away from the direct electrical field recording, the response amplitude drops dramatically. Now, we're going to move through these electrodes pretty quickly. If you want to get a bigger wave one in your ABR, you just want to kind of help to detect the ABR a little closer, maybe see the summiting potential in cochlear microphonic, a tiptrode is possible, a possible option. It's easy to use. I'll show you later how to prepare for placing the tiptrode. It's basically an insert earphone with a wire that you can use as an electrode. Of course, the insert earphone is covered with a conducting substance. In this case, it's gold foil. But again, it's not a real true ECoG electrode because we're not in the electrical field. It's not a near field response electrode. So another option is go to the tympanic membrane. We used to make these electrodes, tympanic membrane electrodes. They weren't approved for use with patients, but that didn't really bother anybody. But now we don't make them anymore. They are much easier to purchase commercially. And one company that makes these is Intelligent Hearing Systems. You can purchase them and use them with any piece of equipment. And basically, it's named after David Lilly, a well-known audiologist who first developed them. And basically, you take a little gauze and soak it in saline and slide that right down the ear canal till it rests up against the eardrum. And then the other end of the electrode, of course, is connected to the ABR system or ECoG system. Here's another tympanic membrane electrode. It's a slightly different design. You can get these online. It's kind of a rubbery gel at one end, and that's, you don't use saline or anything. You don't use paste. Certainly don't use paste or any other gel. You just rest that jelly. It's sticky, but it doesn't stick to the eardrum at one end, and then of course the electrode is connected to the equipment at the other end. And then we have the ideal electrode for the biggest response, a true near field response, and that's a needle electrode. Many years ago, and I can send you the article describing this, in the early 1990s, along with a colleague, we developed a technique for using just a typical subdermal needle electrode that you could find in any OR operating room. You can buy them online. And the surgeon, the otolaryngologist, just takes a bayonet forceps, goes down the ear canal with them under a microscope, places that needle through the eardrum, the posterior and inferior quadrant of the eardrum, and it goes, the needle going straight back runs into the promontory. You're going to miss the ossicular chain, and there's nothing else that you're going to run into, so it's a pretty straightforward technique. And then we take an insert earphone and we insert it in the ear canal to hold the needle in place. So you can see that set up in the operating room. So that's the recording technique. Let's just talk for a moment about analysis. I've already really mentioned there's three things we can measure. We can measure the latency of the response, which doesn't have much value. We can measure the amplitude of the responses, the SP, the cochlear microphonic, and the action potential, and that's what's done most often. And then we can also look at the duration from the beginning of the response to the end. That's very easy to do with our cursors on our evoked response system. Now here are some applications, three major applications of ECoG in adults. One is just to get a bigger wave 1, and there are a lot of good reasons to enhance the size of wave 1. Whenever I'm recording an ABR, I do everything in my power. I use all the techniques I can to detect the wave 1, because once we get the wave 1, we can then look from wave 1 to the later waves, and we can make statements about neural functioning without worrying about the ear. As long as we get the wave 1, we know that the response has activated the ear, the stimulus has activated the ear, and the response we're getting is a neural response. It also tells us we're stimulating the ear we think we're stimulating. If we record a wave 1 from an electrode that's near that ear, then we know the response is coming from that auditory nerve. It couldn't be coming from the opposite side. So we don't really need to worry about masking, even with bone conduction. Another application is intraoperative monitoring using evoked responses. And that's very important because we're usually monitoring neural functioning, auditory nerve, brainstem. And by getting a wave 1, we know that any changes we see in the interwave latencies must be due to something happening to the nervous system, not something happening to the ear. And then the third major application is diagnosis of Meniere's disease. Very quickly, here's an example of ECoG where we're trying to, now this doesn't, we can be doing an ABR at this point, but we're only using electrodes and some of the parameters are changed to get an ECoG as well. So I'm not saying we're doing an ECoG all by itself in these cases. But if we're recording ABR and we've got a high frequency hearing loss, as you see in this picture, I know right away I'm probably not going to get a wave 1 if I put an electrode on the earlobe, certainly not on the mastoid. But if we put an electrode on the eardrum, we probably are going to get a wave 1. If we put an electrode through the tympanic membrane onto the promontory, without a doubt we'll get a wave 1. So in a case like this, whenever I have an adult or child, but particularly an adult, where I know there's a high frequency hearing loss in advance, I always use either a tiptrode or tympanic membrane electrode, unless I'm with an otolaryngologist, and then of course we'll use a transtympanic needle electrode on the promontory. Here's an example of intraoperative monitoring, and this is where the promontory, promontory electrode really saves the day. On the left side of this figure, you see at the very beginning of surgery, They're just starting to open up the skin and work their way down through the fascia to the bone. And so I'm recording an ABR using this ECoch technique, or combined ABR ECoch technique. And with the ear canal electrode, there's a lot of artifact and not much of a response at all. A little bit of wave 1 probably and a 5, but that's it. But at that same time, in the same patient, simultaneously, I've got another electrode on the promontory, and look at that beautiful response. The wave 1 is huge, even though the rest of the waves are easily visible, and you're not dealing with all the artifact because the electrode's so far away from the surface of the skin. So we're away from all the sources of electrical activity in the operating room. Now, on the right hand side of the figure, now the surgery's over. Maybe the tumor's been removed from the auditory nerve, and the surgeon says, well, how do things look? If I only had that ear canal electrode, I wouldn't even want to tell him how it looks. It looks horrible. But if you look down at the promontory recording, beautiful, and everything looks the same. And if we calculate the latencies, there's no difference. So again, promontory placement of a needle electrode is ideal in any ECoch situation. Okay, now in Meniere's disease, the third adult application that I'm mentioning, the main goal here is to calculate the sum-emitting potential and of course the action potential, and then look at the ratio of the two, the SP over the AP, and then we compare that to normative data. Here we have a normal on the top, abnormal on the bottom. Abnormal is always indicated by a bigger than normal sum-emitting potential. It's above the normal range for that relationship, and that always makes you suspicious that this is a case of Meniere's disease. The reason ECoch is so useful in Meniere's disease is it's ear specific. So if a person's dizzy and you're not really sure if it's unilateral or bilateral, the ECoch can help you, and that'll of course lead to perhaps an ear specific management strategy on the part of the otolaryngologist. We know, and this is research goes back to the early 1980s, that patients with Meniere's disease, as you can see on the right hand of this slide, tend to have very enlarged, abnormally big SP-AP ratios, whereas people with retrocochlear and cochlear loss, for the most part, have normal ratios for the sum-emitting potential to the action potential. So this abnormally large SP-AP ratio is a unique feature of Meniere's disease. Okay, we're going to wrap up the ECoch part of this by just mentioning that ECoch is a very valuable tool in the diagnosis of ANSD. And because it helps with the diagnosis and helps us to determine the site of dysfunction, the sites of dysfunction for auditory neuropathy are highlighted in this slide, ranging from the cochlear responses up to the auditory nerve. If we know the site of dysfunction, then we can develop a more logical and more safe management strategy. We can't manage ANSD unless we know where the problem is in the auditory system. Now, you don't normally see an ABR with ANSD. In fact, you don't at all. That's by definition. If the ABR is normal, and it's the same for rarefaction and condensation stimuli, then that's not ANSD, that's an ABR. ANSD is characterized by the absence of an ABR, but you can be fooled initially. If you use a single polarity like rarefaction, you'll get a response, but that's not ABR, it's cochlear microphonic. And if you flip the polarity of the stimulus to condensation, then the cochlear microphonic response turns exactly upside down. If you change the polarity from rarefaction to condensation and there's no change in the response, then that's really an ABR. Now everybody's got cochlear microphonic, so the unique thing here is in auditory neuropathy is there's no ABR, but there is cochlear microphonic. If you have cochlear microphonic and an ABR, that's not auditory neuropathy. And of course, these same patients with a very large cochlear microphonic and no ABR very often, and in fact almost always, have very large OAEs because, again, the outer hair cells are intact, they are pre-neural, and the problem is beyond the outer hair cells. Now, this is an excellent review article. I'd recommend it. The person that's most closely, the name of the person most closely associated with auditory neuropathy is Arnold Starr. Now, Chuck Berlin obviously is very, very knowledgeable as an audiologist, but Arnold Starr is a neurologist, and he really coined the term auditory neuropathy. He's also quite an artist. And so this article with Gary Rance and Arnold Starr, published in 2015, actually includes some drawings that were created by Arnold Starr. And this is a very nice way of showing the cochlea and the auditory nerve and showing the sites for presynaptic auditory neuropathy where the inner hair cells are involved and postsynaptic where the neurons alone are involved. And then sometimes you'll have a combination where it's actually the synapse itself that's involved. The outer hair cells, by definition, are not involved in auditory neuropathy. Here's a picture of Arnold Starr a few years ago. He's now retired. I think he's got a little art gallery somewhere in California. Anyway, this is the article that I highlighted that started the term auditory neuropathy, but people were describing the same pattern: normal OAEs, no ABR, normal OAEs, hearing loss, for quite a few years. And I'm not showing you all the articles on auditory neuropathy, obviously. But if you were to do a search, and I did this a few days ago, if you were to do a search of just auditory neuropathy, a literature search, you'll get more than 700 articles on the topic. So we have a lot of published information to go on as we evaluate and manage patients. Now, I'm not going to talk much more about auditory neuropathy because I don't want to cut into our ABR time. But how do you know which patients might be at risk? Well, that's all been worked out. These are the major risk factors. Any child in the intensive care nursery is at risk, but keep in mind that roughly half of all children with auditory neuropathy may actually have a family history of auditory neuropathy or a genetic explanation. Now, this is from that great article by Gary Rance and Arnold Starr. I'm not going to go through this table in detail, but I recommend the article because it helps you sort out the etiologies or causes for auditory neuropathy and relate that to where the disorder is or where the site of dysfunction is in the auditory system. And then that in turn is related to abnormalities in ECoG and ABR. So I recommend this article to you. You'll learn so much about auditory neuropathy from this article. Now, auditory neuropathy is not as rare as we used to think. And when you get into the children with hearing loss, it's actually quite common. I mean, by that I mean at least 5% of all children with hearing loss have auditory neuropathy. And it's estimated if you have a patient with a severe to profound loss, there's a 15% chance that it's auditory neuropathy. So the bottom line here, the message is always suspect auditory neuropathy and do everything you can to rule it out in every child that you evaluate. There are guidelines for auditory neuropathy. These are clinical guidelines, and these will help you to identify, diagnose, and manage. And these guidelines always include ECoG as well as OAEs as required techniques. Here's another set of guidelines from the UK, a little more recent. So any of you who are seeing children, you need to know the risk factors for auditory neuropathy and how to detect it and at least get started in evaluating it. So I would recommend you go to these guidelines. All right, so that's ECoG. Now we're moving on to ABR. We've got a lot of material to cover, a tremendous number of slides to go. So we're going to fly through this. I have already mentioned the book, and I'm going to mention also that the biggest part of this book is ABR. So these are the chapters in the book, chapters 1, 4, 5, 6, 7, and 8, that focus only on ABR. Now, I've received quite a good feedback and good response to this book. But some people said, I'm mostly interested in ABR. I like I like the fact that you're covering all responses, but I'm really interested in ABR. Could you publish a book only with ABR? It would be a shorter book, less expensive, and so I'm going to do that. And in 2019, I'm going to produce an ABR book called Clinical Measurement and Application of ABR, but it also will be in hard copy in case you don't want the e-version. So keep your eyes open for that. Historically, we can go back to the early 1970s, around 1970, for the discovery of ABR by two people. Now, the real person who was instrumental in the discovery is Robert Glambo, shown on the right-hand side here. It was his work, his research, with a postdoctoral student of his, with a protege, Don Jewett, that really led to the discovery of ABR. But the first articles on ABR were written by Don Jewett. And this is the classic published in 1971. The ABR revolutionized pediatric audiology, changed the way we do things. We can now evaluate infants, young children, they can be sleeping. It was an incredible development. I don't have time to go into the anatomy of the ABR, but it's something you really need to be familiar with. So there's a figure from my e-handbook. Basically, the wave 1 comes from the auditory nerve near the cochlea, where you're on the side that you're stimulating, the nerve connected to the ear you're stimulating. The wave 3 comes from the pons, the lower brainstem, mostly the ipsilateral side, and it could be a lot of the crossing pathways produce wave 3. And wave 5 arises from the lateral lemniscus as it approaches the inferior colliculus, but probably most of wave 5 comes from the lateral lemniscus on the opposite side, contralateral to the stimulus. There are many neurons in the auditory system, but only one type of neuron, the onset neurons, generate the ABR. All the rest of the neurons don't seem to contribute to the ABR. And if you look at the structural types, the shapes or the morphology of the neurons that produce the ABR, they're called the octopus cells. So this is an important point. ABR is not a test of hearing because much of the auditory system is not being measured with ABR, including most of the neurons in the auditory system. So it's not a test of hearing, but we can use it to estimate hearing status when we can't use techniques like pure tone audiometry. Another reason ABR is not a test of hearing is the ABR is only produced by the axons. So this is a picture of a nerve, a diagram of a nerve, and only the axon produces the ABR. Not the terminals at one end or the dendrites at the other. So the auditory system has all these complex nuclei that are processing auditory information, including speech, but we're not assessing them with the ABR. We're only measuring a response from axons that are stimulated, thousands of them all at one time, that produce a big enough response for us to record with our electrodes. And one last little point about anatomy. Only when the neurons are lined up parallel do we actually record an ABR. So again, there may be many neurons in a nucleus that are oriented in all different directions, and basically all those responses get canceled out. That's called a closed field. Only an open field where there's space between the neurons and they're kind of arranged in a parallel fashion, only that arrangement of neurons produces an ABR. So, I'm kind of basically saying ABR is not a test of hearing. There are many weaknesses to it, and yet, as you know, and as we'll discuss, it can still be a very valuable tool in clinical audiology. Okay, so these are all the reasons why ABR is not a test of hearing, and in the interest of time, I'm not going to go over them, but it is a very important point to keep in mind. That's one reason why we use the cross-check principle. We don't want to use just the ABR to assess a child's hearing status. We want to make sure that the ABR results are cross-checked or validated or backed up by the results of other tests that we do. And when they all agree, then we can be pretty sure that we're getting an accurate diagnosis of hearing loss. Now we're going to very quickly in the next 20 to 30 minutes review this flowchart, starting with the stimulus that we use for ABR and how we present it to the ear, the transducer options. And then we're going to go through some of the ways we record the ABR electrodes and where we put them, electrode types. And we'll also discuss things like filtering the response to get rid of all the unwanted brain activity and maybe muscle activity and even other electrical activity from power sources. And we'll talk about some of the major factors that influence ABR that you must take into account when you're analyzing it. This is another figure from my e-handbook. So we've got the same kind of protocol that we just kind of reviewed for ECoch, although there are variations. Insert earphones are always going to be used for ABR, but you need to have a bone oscillator as well, and we'll talk more about that in a bit. You could use a loudspeaker for ABR, but most people don't. So if you have insert earphones and a bone oscillator, you're going to take care of most patients, but there are some patients that will come along with oral atresia. They won't have an ear, they won't have an external ear, they won't have an ear canal. And in those cases, you need to use supraoral earphones. So you want to have two types of earphones for air conduction, insert and supraoral, and then you need your bone oscillator designed for that particular ABR system. The stimuli, clicks and tone bursts, can both be used. We'll talk about that. The duration is always 0.1 milliseconds for clicks, but for tone bursts, we want a slightly longer duration. Not much longer, but we want a duration that's maybe 4 to 5 milliseconds in length at most. And so we usually define duration for tone bursts based on the cycles. Rarefaction is the ideal stimulus for ABR, but if that doesn't produce the response we are interested in, that is the optimal response, we can always switch to condensation. The rate of stimulation is very important, and we're going to talk more about that later, but you want to use the fastest rate of stimulation that produces the best response. So you don't want to go too fast, but you definitely don't want to present the stimuli too slowly. We're always varying intensity. We'll talk more about that in a moment. So insert earphones, well, I could go on for 10 or 15 minutes singing their praises and how all the advantages. Here they are listed. But I would never do an ABR without insert earphones, particularly in children. The advantages far out. There really are no disadvantages, and there are so many advantages. If you get a little adapter at the end of that red tube for the insert earphone, you can see a little black adapter. If you use an adapter like that, which you can buy from any manufacturer, then you can start using the same tips you use for tympanometry on that adapter, and you don't need to worry about the size of the insert earphone. You can always find the right size. Now, polarity. I mentioned rarefaction polarity. Negative polarity is best. This is another figure from the book. Why is that? The negative polarity, to make a long story short, the negative polarity pushes, when it gets to the cochlea, when that stimulus finally activates the cochlea, pushes the basilar membrane upward. And that deviates the tallest stereocilia toward the tallest. All of the stereocilia get deviated toward the tallest when the basilar membrane moves up. And when that happens, the hair cells and the cochlea is activated. When you use positive stimuli, positive pulses or condensation, you actually are pushing the basilar membrane in the wrong direction. Eventually it comes back and you will produce a response, but it's not optimal. Now, I mentioned rate a moment ago. What is the optimal rate? Well, it's not a specific number. The optimal rate is the fastest rate that you can use that will give you the best response. Why is fast speed of stimulation so important? The faster the rate, the quicker the ABR goes. The quicker the ABR goes, the more information you get. And remember, we're going to be using this technique in children, and children tend to not sleep very much on their own. So we want to try to do an ABR at least within a half an hour, and I'm going to show you some techniques that will allow you to record an ABR if the child is quiet, even for 15 minutes. you'll get a good response. So for a click stimulus, for these reasons, as you can see here, I use an odd number somewhere in the low 20s, like 21.1. When I get to the tone burst, I'm not interested in wave 1, so if I go faster than the wave 1 disappears, that's okay. But I want to really get information quickly because I've got a lot of tone bursts to present at a lot of different intensity levels, so I use a rate of 37.7. And if you look over to the actual waveforms, you can see that by going up in rate, we can easily get it up into the 30s without any problem. The ABR still looks good. It's not until we get to faster rates that there seems to be some deterioration. Now, if we just look at stimulus rate alone and using the fastest rate we can get away with, let's assume we've got 4 stimuli per ear, a click and 3 tone bursts. So we're trying to recreate an audiogram. We're using 4 intensity levels. This is just for an assumption, just for our example. 2 replications per intensity level. We wouldn't normally do that, but let's say we do. And of course 2 ears. So we get basically 64 separate ABR waveforms in a single ABR for a child. If we use a rate of 11 per second, that would take us an hour and a half. But if we use a rate of 37 per second, it takes us less than half an hour. So you can see that rate alone has a huge impact on time it takes to perform an ABR. Okay, just a couple points about stimulus intensity. As you all know, increasing the intensity of the stimulus reduces wave 5 latency. And we can define that with that latency intensity curve over on the left. And it's very important to have normative data for that and to understand that principle. Now, once we get up to intensity levels of about 60 dB, higher intensity levels don't change the latency very much. Very different for amplitude, as shown in the right-hand part of the slide. As we go up in intensity, the amplitude keeps getting bigger and bigger. So what's the point here? Well, if we are not seeing a real clear wave 1 or a real clear good ABR at 60 or 70 dB, go up to the highest level. Very often the ABR pops right out. The wave 1 just appears out of nowhere when you go from 80 to 90 dB. So increased intensity will have a much more dramatic impact at high levels on the amplitude than it does on the latency. Okay, and we also know there are some general, in addition to the decrease in latency, as we increase the latency, the intensity of the stimulus, there are other changes in the ABR. As we go down in intensity, for example, the amplitude gets smaller for all waves, but since the wave 1 is typically the smallest of all of them, it disappears first. We don't usually see wave 1 below about 40 dB NHL. Okay, now we're moving on to acquisition parameters. Well, there's not time to go into all of this. We've still got lots of material to cover, so I'm not going to read everything that's on this. I'm going to say that all of these parameters are important. The filter settings, the electrodes, amplification, the analysis time. We need to make sure that every parameter that we use is evidence-based. There's a reason for every parameter that you see on this screen, and it's supported. The reasons are based on research that's been published over the last 45 years. Now, boy, there's just so much to cover in so little time. I'm going to be referring to electrodes, and you've probably heard the terms already: non-inverting electrode and inverting. Typically, the non-inverting electrode is the one up on the forehead, and the inverting electrode is the one near the ear. And the reason we use these terms is the non-inverting electrode, when it's plugged into the amplifier, that input doesn't get inverted. It goes straight on through and gets amplified. The inverting electrode input gets flipped upside down, gets inverted, and then it's added to the other input and gets amplified. And basically this is a strategy, this is from my book also, this is a strategy to get rid of electrical activity, usually noise or interference artifact, that's common to both electrodes. The term is called common mode rejection. Where do you put the electrodes for ABR? Well, we're pretty lucky compared to EEG techs. They may have to put 30 electrodes on a patient. We've only got to put 3 or 4 on a patient. We've got an electrode non-inverting is going to have to be somewhere up near the high forehead to the vertex. And I'm going to show you in a moment that the high forehead, which is indicated FZ, F for frontal lobe, Z for midline, it's by far the best option. We need to have an electrode near each ear, and I usually put it on the electrode on the earlobe. The earlobe is a far better choice than the mastoid for a number of reasons. And then a ground electrode, and the easiest place to locate that is the lower forehead. So here we have two patients. One of my former students at the University of Florida, when I was there, she graduated, of course, with her AUD, showing the electrodes, the non-inverting up toward the top of the forehead, the ground electrode below that, and an electrode on each earlobe. And over on the right side is my grandson 2 or 3 years ago, who was kind enough to be a subject, showing the same location for the electrodes. Now, some of you may have been told, well, you need to use an electrode on the top of the head, CZ. Don't use the forehead. But that's really not supported by research. Research over the years shows that there's almost no difference in the ABR recorded from the top of the head versus the forehead. In fact, you can actually sometimes get a better wave 5 for the forehead placement in young children. And these figures show that. If you look at the top and the bottom waveforms, the top is the forehead, the bottom is the vertex. There's virtually no difference. So I've listed some of the advantages of the forehead placement versus the vertex placement at the bottom of the slide. And I've not used a vertex electrode, and I don't think ever. We've used forehead right from the beginning, and there are so many advantages, there's no reason to go to the vertex, particularly in a clinical setting. In a laboratory setting, that's different, but in a clinical setting, forehead's best. What type of electrode should you use? Well, there are different factors. Cost is one of them. If you use all disposable electrodes, as indicated by A, you're throwing the whole electrode away at the end. It's more expensive. On the other hand, if I'm screening newborn babies, that's what I want to use because I don't want to run any risk of infecting them. Those electrodes, example A, come in a little packet. They're sterile when they come out, so you're not going to infect the child. A good combination of cost savings, but also not infecting a person, is to use a disposable electrode that you clip onto a wire that you reuse. And the disposable electrode on the far right is actually one of the better ones for many reasons. It's very sticky and it really holds to the skin well. However, when I'm recording ABRs from older children and adults, I always use reusable electrodes as indicated by C. Here on the left-hand side of this slide, you see a bunch of reusable electrodes, one for the high forehead, the non-inverting, one for the ground, one for each ear lobe. You can see those little clips are for the ear lobes. I have a set of electrodes like that right where I'm lecturing, actually, in my desk. I'll use a set of electrodes like this for 20 years, 25 years. If you take good care of them, you clean them up, you don't let them sit around in liquid, then they'll last forever. So it's very economical and you'll get very high quality responses. And these are the materials on the right hand side that we can use to prepare the skin and affix the electrodes to the skin. I've already mentioned tiptrodes, so we won't spend any time on that. The tiptrode's a great option for enhancing the size of wave 1. Now, how do you actually excuse me, get good impedance with a tiptrode if you're putting it down in the ear canal? Well, what you do is you take a cotton tip swab, put a little of the gritty new prep on it, pull the ear canal up, straighten out the ear canal by pulling the pinna up and out, and then just rub around very vigorously into the ear canal. Most patients have no problem with that, even older children, and then you just slide the tiptrode in and you'll have very good impedance. You got to plug the electrodes in, obviously, and you have to take a little time to study the system or the electrode box that's used for your equipment. If you have two channels, then usually you'll have channel 1, channel 2. You'll have a non-inverting and an inverting input for each channel, and then there'll be one common ground electrode for both channels. With other ABR systems, you actually have a little head-shaped box that you can plug the electrodes in. So obviously, if you don't plug the electrodes into the right input, you're going to get make some serious errors in your ABR measurement. Filter settings. Well, that's important. You want to filter out what isn't a response, and you want to make sure you don't filter out what is the ABR. So typically you want to filter from 30 Hertz to 3000. Any energy under 30 Hertz is not ABR. Now there's a lot of EEG, a lot of brain activity under 30 Hertz. In fact, most of the brain activity is under 30 Hertz, but that is not ABR. That's just ongoing brain activity. So filtering that out will help you see the ABR. Likewise, when you get above 3000 Hertz, anything you record is either muscle twitching or electrical activity, but it's not ABR, so you want to filter that out. And we know that by doing spectral analysis of the ABR. So here's my ABR from many years ago, back in the 80s. I did a spectral analysis of the waveform, which is on the left, and showing the energy in the response over the frequency domain. And you can see most of the energies below 200 Hertz. Some of it's around 500 Hertz, some of it's around 1000 Hertz. But there's nothing really below 30 Hertz. So we take all the brain activity and muscle activity, everything else that we're recording, and we filter out the frequencies that can't possibly contain ABR, which helps us to see the ABR more clearly. Sometimes by using different electrodes, we can actually get rid of different electrode arrays. We can get rid of a lot of the artifact. You might run into this kind of artifact in the nursery or in the operating room or even in any place where there's a lot of electrical interference. And so sometimes getting rid of electrical activity that we don't want is hard because the artifact that we're picking up, the electrical artifact, happens to be right within that 30 to 3000 Hertz region. So another strategy is to use different electrode combinations in hopes of getting rid of the artifact. And this is just an example showing that recording from one ear to the other in both of these children actually got rid of all the artifact. How much time should you look for the response after the stimulus? I highly recommend 15 milliseconds. 1 millisecond for pre-stimulus baseline and then 14 milliseconds after that. And these are all the different reasons. 10 milliseconds is too short, but when you get up to 20-25 milliseconds, it's really too long. How much averaging should you do, or how many stimuli do you need to present? Well, there's no one answer. You need to present enough stimuli to give you an ABR that's 3 times bigger than any background activity. Now, people have studied this for years, and as you present more and more stimuli, usually the amplitude of the response increases and the amplitude of the background noise decreases. Of course, the more stimuli you present, the less benefit you're going to get in terms of signal to noise ratio. And you can see on the right side of this slide, when the patient's really quiet, there's no noise, you actually get a very, very clear response, even with just 100 stimuli. But when there's more background noise, you're going to need to present many more stimuli. So the goal, again, is not to present 2,000 stimuli under all conditions or 3,000. The goal is to get a clear response, an ABR, a signal, which is at least 3 times bigger than all the background noise. And this is from a wonderful set of clinical guidelines for ABR in infants developed in the UK. So here's another summary. I keep mentioning this because this is one of the most important, probably this is the most important concept in ABR. What are you doing when you're recording an ABR? You're trying to detect a signal embedded within all kinds of electrical noise. noise from the brain activity that isn't ABR, noise from electrical activity that isn't obviously the ABR, noise from muscle activity, which is not ABR. You're trying to sort out the ABR from all of this background activity. So whatever you can do to make the ABR bigger and the noise smaller is something you should do. And as soon as the ABR is 3 times bigger than the background noise, you can stop. If you're only at 500 stimuli, stop there. At high intensities with a quiet baby, you can usually see the ABR very clearly after 500 stimuli. But with a noisy baby, restless baby at lower intensities, you may need to use many, many more stimuli. So if you use the right protocol, it's evidence-based, all the parameters are carefully selected, and you have a quiet patient, you'll always get the best ABR you possibly can from that patient. Okay, now I'm just going to quickly go through this because we're reaching an hour, and what we're going to have to do here is this lecture is going to be a little more than an hour, and then the third lecture will be a little less than an hour, so that you'll have a total of 3 hours. I know I can't go beyond that limit. One way you can really speed up ABRs, as I already mentioned, is increasing the stimulus rate to the fastest rate that still produces an optimal ABR. But another very important strategy for speeding up the ABR, which means getting more data and less time, is by stopping the signal averaging as soon as you see a clear ABR above the noise level. And this slide summarizes that. If we're stopping the ABR as soon as we're seeing a clear ABR, we can, rather than using a fixed number of stimuli, always the same number of stimuli, we can reduce the test time. I've recorded ABRs in less than 15 minutes many times. It's not hard at all. If you have a quiet baby, you can perform a full tone burst ABR sequence, 3 tone bursts per ear, plus the clicks in less than 15 minutes. But the only way you can do that is to make sure that you don't average anymore, you don't present any more stimuli after you see a clear ABR above the noise floor, 3 times bigger than the noise floor. Okay, moving on quickly to ABR analysis. Very straightforward. You're all familiar with this, so I'm not going to spend much time on it. We mostly analyze latency. We analyze the absolute latencies of each wave and the relative latencies between the waves. Amplitude it's good to analyze it, but it's not as important. Usually we only evaluate the amplitude for wave 5 and wave 1. Now, there are variations in the shape of waveforms, their appearance, their morphology, which you need to get used to as a beginner when you're recording ABRs. Not everybody has a clear wave 4 and 5. It's not uncommon for a person to have what looks like a 4 and a 5, but the 5 kind of extends out and then it finally starts to drop off. Most audiologists will mark the shoulder at the very end of wave 5 rather than the peak. But you need to be familiar with these and use the same criteria to analyze every patient, and obviously the same criteria to analyze the right and left ear responses in order to have accuracy in your ABR measurements. All right, so in the interest of time, I'm not going to go through the analysis. Obviously, there are steps you need to go through that you want to kind of discipline yourself to follow. Now, we're going to talk about tone bursts in just a second, but click ABRs, even though we don't want to stop at the click, we want to go on to the tone burst if we've got a child who we might be fitting with a hearing aid if they have a hearing loss. We can get a lot of information out of the latency intensity function, the shape of the latency intensity function. So even though I'm just using a click at the start of an ABR, I only spend a minute or two performing click ABR before I move on to the tone burst, I can usually differentiate between conductive and sensory and sometimes neural just from that looking at the latency intensity functions. Now I mentioned earlier that once we get the ABR, we have to take some factors into account as we analyze it. For young children up to age of 18 months, we've got to take age into account. With adults, we have to take gender into account. The latencies are statistically shorter for ABR in females than males. For anyone who might have an abnormal body temperature, warm or cool, we have to take body temperature into account. So that includes children in the intensive care nursery, children in the operating room, or any child or any adult who is sick, who has a fever or has poor homeostasis, poor control of their temperature. And then certain medications, sedatives have no effect on ABR, but certain anesthetic agents do produce a slight effect. So we have to take those into account. Now for the click ABR, if we look closely at the ABR at the very beginning, as we record with a click, we can always differentiate between either a normal hearing person or at most a very mild hearing loss in the high frequencies, to a conductive, to sensory, to neural, or to ANSD. Time does not permit me to go into all of this in detail, but we're looking at the wave 1 latency delays to identify conductive. We're looking at poor morphology and maybe no wave 1 to identify high frequency sensory. We're looking at interwave latencies that can't be explained by temperature or can't be explained by the the anesthetic that the person's getting, all to determine with the click ABR at the very beginning of our assessment what kind of hearing loss we're dealing with, or what kind of auditory dysfunction, the type of hearing loss. So that's all summarized here. So I'm not going to go over this, but you want to start out, in my opinion, with a click ABR. Don't spend more than a couple minutes on it because it provides you with so much diagnostic information that will guide you with the rest of your ABR assessment. Okay, we already covered that. Age, we're not going to talk more about it, but the ABR in an infant does not look like the ABR in an older child or an adult. So it's important to recognize that latency shortens and certain waves, like wave 3, begin to appear with maturity. Okay, now we're going to spend the rest of our time, and probably it'll end up being about 15 minutes, talking about tone burst ABRs. You cannot perform a pediatric ABR where the goal is to estimate hearing thresholds without using tone burst. You need to have frequencies from 500 hertz all the way up to 4,000 hertz, not just a single frequency, multiple frequencies, as well as the click. Now, a click ABR does correlate with hearing, but only hearing up in the 2 to 4,000 hertz region. So this has been shown many, many times over the years. If you look at the threshold for a click ABR, click evoked ABR, and compare that to thresholds for the audiogram, the correlation is best with the threshold for pure tones in the 2 to 4,000 hertz region. That's the part of the cochlea that produces the ABR. So if you have a click ABR that down to 50 dB, for example, and there's a clear response at 50 dB, nothing below 50 dB, you know that somewhere in the 2 to 4,000 hertz region, hearing is around 50 dB. So you do get some threshold information, but only for a very limited frequency region. Now we know that tone bursts have been around since the late 80s, early 1990s. We know that there are ways to manipulate the tone burst to get them to be most frequency specific. We can use Blackman windowing, for example, to shape the onset of the tone burst. And you can see the lower left-hand stimulus is very frequency specific. We can eliminate the plateau to maintain frequency specificity. So I'm not going to go into these details, but we can shape develop our protocol for ABR and utilize these parameters just the way we want them to get the most frequency specific stimulus, which is going to give us the most accurate threshold measurement in different frequency regions. Now keep in mind that the tone burst ABR does not look like the click ABR. And the lower the frequency of the tone burst, the more different the waveform. So I've identified three differences here, major differences, between the ABR elicited with clicks versus tone burst. morphology, the presence of wave 1, which disappears as we get to the low frequencies, and the wave 5 latency, which of course increases as we get to the lower frequencies. Now you don't really need to worry much about latency for tone bursts. You do for clicks, but not for tone bursts. We don't call a tone burst ABR abnormal or normal based on latency, but it is helpful to know the general latencies for tone bursts just so you know whether or not you're looking at wave 5. So we can help to identify the wave 5 by determining whether it's in the region for latency that we would expect it to be. Again, low frequency tone bursts produce longer ABR wave 5s. Why? It takes about 5 milliseconds to travel along the basilar membrane. The traveling wave takes about 5 milliseconds to go from 4,000 hertz up to the 500 hertz region in the apex. Now our main goal, of course, in doing an ABR with tone bursts is to estimate thresholds so that we can then take hearing aids, amplify the speech spectrum, speech energy, so that the faintest, softest speech sounds are just audible. We can't do that with infants using behavioral pure tone audiometry, obviously. So we're trying to get that same information by using frequency specific stimuli, tone burst, and then with that information, the patient can either be fitted with a hearing aid, or we might determine the hearing aid is not going to help and a cochlear implant is the best option. Now, there are hundreds of articles describing ABRs in children, and we now know that in children who probably have roughly normal hearing um, and a mild loss, that we can get pretty close to thresholds, but we can't always get right to thresholds with the ABR. In other words, at 1,000 hertz, we can get down to about 10 dB of the behavioral threshold, but then we have to subtract 10 dB to get the estimated hearing level. For lower frequencies, 500 hertz, we actually have to subtract a little more. So if we have an ABR down to 35 dB, that probably tells us hearing at 500 hertz is no worse than 20 dB. When we get to the high frequencies, there's not much of a correction very often. So that's all for normal hearing subjects, but it changes a little when we get into hearing loss. So say we're not recording an ABR until we get up to 50 to 60 dB. There's no wave 5. So now we know we're dealing with a hearing loss. Now there's very little difference between the actual ABR threshold and the child's behavioral threshold. Still a little more difference for the low frequencies, but very, very little. Now, this is a very complicated slide, and I'm not going to spend too much time on it. These are articles that I reviewed in my book, and certainly you can read the original articles. But the bottom line is we need to estimate thresholds in infants, taking into account the frequency of the stimulus and the amount of hearing loss the child has. And so we're going to correct more to go from ABR to actual behavioral threshold, more for low frequencies and more in normal hearers, and there's very little change or difference between the ABR threshold and the actual behavioral threshold that we're trying to record when we get into higher frequencies and we get into children with hearing loss. Okay, so there's a lot of ways we don't have time to talk about a lot of ways we can shorten the test time by going to faster rates, less averaging than we have done in the past, so only averaging until you see a clear response. All of those techniques can help us easily record a full tone burst and click ABR in less than 30 minutes. Now I promised that I was going to go through some later new advances or the latest techniques for each of these topics, and for ABR I've chose the chirp. Now we're really moving on in time here, so I don't want to spend too much time. I will say that chirps are available. They're available on most ABR systems. On some ABR systems where they use chirps that are the original chirps developed by Klaus Elberling, who's an electrical engineer or engineering type person in Denmark, and the CE chirp is always a Klaus-Elberling chirp. It's basically with your typical stimulus, whether it's a click as shown in the bottom slide of the slide or a tone burst, you're activating with a click the entire cochlea. With a tone burst, you're activating a region of about an octave band of the cochlea. But the problem is the first part of the cochlea to get stimulated produces the ABR. So with a traditional click, a traditional tone burst, a very small part of the ABR, a small part of the cochlea is actually producing the ABR. And the rest of the cochlear stimulation is wasted. So the goal of the chirp is to maximize activation of the cochlea that's contributing to the ABR. So if we look at this slide, the high frequencies are shown to the right, the low frequencies are shown to the left. If the low frequencies in a chirp they're always being presented a little earlier, about 5 milliseconds earlier, and the high frequencies are presented later. The lower frequencies being presented earlier are on their way to the apex of the cochlea, and they reach the apex of the cochlea, the 500 hertz region, for example, before the very highest frequencies, or right at the same time that the highest frequencies reach the cochlea. So the concept of a chirp is you present the lower frequencies a little earlier. They're all one stimulus. This is a chirp stimulus. It's all one stimulus. But the lower frequencies arrive at the stapes foot plate earlier than the mid frequencies, and they arrive earlier than the high frequencies. So the entire cochlea is activated simultaneously. Well, if you do that, if you activate the 500 hertz region, 1000, 2000, 4000, all at the same time, theoretically, you're going to get a much bigger response. Much bigger than if you presented a traditional click and only produced the ABR from the very highest frequencies that first activated the cochlea. So that's the concept here. You're basically shifting the wave 5 for the lower frequencies to a little earlier to match up with the wave 5 for higher frequencies. Now, it's not easy to do, and it takes very complex mathematical equations, but that has been done in a way which allows you to record ABRs. Now, one question I had was if you're using chirps and you're activating more of the cochlea, maybe the intensity level would be greater. We don't want that. We don't want a higher intensity level for chirps. Let's say you took 20 dB, but really you had more than 20 dB for the chirps than the traditional. Then all your threshold estimations would be inaccurate. But it turns out people have actually calibrated in the ear canal or measured chirp versus traditional tone bursts and chirp versus traditional clicks, and the intensity levels are equivalent, as shown in this slide. Another question, at least with the octave band chirps, which the tone burst chirps, is the frequency specificity, or is the energy in each of these frequencies the same for the chirp versus the tone burst, and as shown in this slide, that is the case. So the chirps and the tone bursts can be used and the chirps and the chirp clicks, can be used interchangeably. They're not going to be any different in frequency or intensity. Well, the main purpose of using the chirp is to get a bigger ABR, and the bigger ABR means you don't have to present as many stimuli to see it. And if you don't have to present as many stimuli, it's not going to take you so long. So the main advantage of chirp ABR is saving test time, getting you to the point where you can probably do the test while the child is sleeping naturally. These are electrical and acoustical waveforms for chirps, just showing that there are frequencies being presented a little earlier for the low frequencies and a little higher for the high frequencies. And there's a lot of literature on chirps, dozens and dozens of articles, and the research is all very clear. If you look at the traditional click ABR shown in the bottom line of this figure and compare it to the chirp ABRs shown at the higher waveforms toward the top of the figure, the amplitude of a chirp ABR wave 5 is up to 2 times bigger, and this is very consistent. Not in every patient, not at every ear or every stimulus, but on the average, chirp ABRs are twice as big as traditional ABRs. And I've studied this extensively. I'm going to have to save some time here by just going through these slides quickly, but I've looked at this concept of, well, what kind of ABR do you get with a regular click, and what kind of ABR do you get with a chirp, which is more effectively stimulating the cochlea. And if you look down at this slide to the 20 to 15 dB range, you can see a clear chirp ABR at 20 dB, nice wave 5. It's barely there for the traditional 20 dB click. And then at 15 dB, there's not a chirp or a regular click ABR. In this case, now I'm using a 4,000 hertz chirp, and I'm questioning, well, how quickly can I get the data? Because the chirp seems to be producing a big response. So I stopped averaging as soon as I saw a wave 5 that was 3 times bigger than background activity. And when I did that, I was able to record an entire threshold estimation for 4,000 hertz in just over a minute. And this is very, very typical. Here's another stimulus, 2,000 hertz. Same concept. The chirp ABR produces such a big wave 5 that you can reach that signal to noise ratio of 3 times the wave 5 compared to the background noise in almost no time. So here I almost never had to present more than 500 sweeps. And so again, it took 1 minute to find the threshold for 2,000 hertz. Well, you can start doing the math and seeing how you could easily get an ABR for 4 different stimuli, 1 click, stimulus, 3 tone bursts in both ears in less than 15 minutes. Now this is a slightly different variation of the advantage of a chirp, another 4,000 hertz tone burst versus 4,000 hertz chirp. But look at the bottom of these waveforms. You get down to the level where there's a clear wave 5 for 25 dB and there's no wave 5 at all. That was with a chirp, with the regular 25 dB tone burst. So sometimes you'll actually get a more accurate threshold, a lower threshold level with the chirp than with the traditional tone burst. So now we're going to move from chirps on to bone conduction, and that'll wrap things up here. Bone conduction ABRs are necessary, just as bone conduction pure tone audiometry is. You should be prepared to record a tone burst, a bone conduction ABR, and those of us who follow the Joint Committee recommendations must do this because they're right in the recommendations. If you have any indication that there's a conductive hearing loss of any type, you need to use bone conduction ABR. You need to be prepared to use it. Have a bone oscillator, have a protocol, and be skilled in recording bone conduction ABR. Now, the protocol for a bone conduction ABR as opposed to air conduction is very similar. So you don't have to have a different piece of equipment or anything. You have to have a bone oscillator, obviously, and you need to have put it on the mastoid. But other than that, you're using similar protocol. The only main difference is we use an alternating polarity for bone conduction, whereas we use rarefaction for air conduction. The bone alternating polarity is usually necessary with bone conduction to minimize stimulus artifact because our electrode's not too far away from the stimulator itself. Now, I want to point out there is a new bone oscillator. It's called the B81. It's a modern design. You can actually hold the bone oscillator because the outer casing is not connected to the part that oscillates. But another big advantage is it gives you a much higher output. So for any ABRs, if you're buying an ABR system or you want to upgrade your system, I would recommend the B81. Now you can put the bone oscillator anywhere in the temporal bone. If you've got an infant without much hair, or any patient without much hair, you don't have to put it on the mastoid. And there's an advantage of putting the bone oscillator way up on the top of the temporal bone, up near the parietal bone, because then you're away from the electrode, which is near the ear. The goal with bone conduction, and this kind of brings us back to the ECoch concept, is to record a clear wave 1 on the side we're stimulating. If we can stimulate one ear with the bone oscillator, put it on a mastoid, and we can record a clear wave 1 from the electrode on that ear, we know that's the ear that's responding. We don't have to worry about masking. And to be extra certain, we can go to the opposite ear, and if there's no wave 1 from the electrode on the opposite ear, only a wave 1 from the electrode on the stimulus ear, we're 100% certain that we're stimulating the test ear. Okay, I've already covered this, so I don't know why we have two of those, but where that's good, we're going to move right on to the auditory steady state response. And I'm only going to barely introduce you to this concept and then we'll stop. The auditory steady state response has been around since the 1980s, but we haven't had clinical equipment for recording it up until the last 10 years or so. Now, here are just some of the many devices that you could purchase or use in the clinic to record ASSR. And I would recommend that if you're going to buy an ABR system, make sure it has ASSR capacity, because ASSR can really help you in recording a response. So we're going to stop right here. And the third lecture, we're going to pick up with ASSR. And then after that, we're going to talk about how you can get your patients to sleep, to fall asleep, even without sedation or without anesthesia. And then we'll wrap up the third hour it'll be a little less than an hour, with a review of cortical auditory evoked responses. So that's the end of part 2.